I'll be presenting the secondary points as substantiating the actual health risks of using medical marijuana. According to the Journal of Current Psychiatry Reports, one study conducted a current review of literature. This study analyzed the peer-reviewed medical literatures of studies from 1998 until 2013, specifically assessing the association of marijuana use and physical diseases. The author states in the article that with the advent of legalization of marijuana for medicinal and recreational purposes, and the increased use of marijuana, healthcare providers will be increasingly confronted with marijuana users as patients in clinical environments. There is no doubt that this is a controversial issue and one that will be seen more and more by physicians. According to the World Health Organization, cannabis is by far the most widely cultivated, trafficked, and abused illicit drug, and as of now, as stated earlier, marijuana is designated a Schedule I medication by the U.S. Drug Enforcement Agency. The main issue with the argument stated that marijuana does not cause harmful effects is that we cannot actually prove this with enough substantial evidence. This is mainly due to the fact that it has not been approved by the U.S. Food and Drug Administration. According to the FDA, most drugs that undergo preclinical or animal testing never even make it to human testing reviewed by the FDA. The drugs that do must undergo the agency's rigorous evaluation process, which scrutinizes everything about the drug from the design of clinical trials to the severity of side effects to the actual manufacture of the drug. After attempting this exceptionally long process, it is still at the discretion of the FDA that marijuana is not safe and effective for public use. This limits the amounts of studies, particularly with human subjects, which in turn weaken any evidence by these studies due to the effect of convenient sampling, small sample size, and selection bias. It is unethical to consider even testing the effects of an illicit drug on human subjects without first being approved by the FDA for study. This leaves practitioners with little factual reference to side effects that result from medical marijuana's application. The analysis conducted through this comprehensive review of current literature concluded that there is a possible association between marijuana use, physical health conditions, grouped by immunologic, neoplastic, gastrointestinal, gynecologic, and metabolic effects. To provide a brief biologic background of marijuana, I'll use the World Health Organization's definition. Cannabis is a generic term used to denote the several psychoactive preparation of the plant Cannabis sativa. The major psychoactive constituent is THC, and compounds which are structurally similar to THC are referred to as cannabinoids. More than 60 cannabinoids have been identified in marijuana, and like other substances of abuse, exposure to inhaled marijuana has the biological basis for causing physical health effects, in that cannabinoid receptors are endogenous to the human body, as previously stated. I will briefly explain one specific area which has substantial evidence of physical effect from marijuana use. Pulmonary function is a controversial and widely studied effect of marijuana use. From the analysis of the current peer-reviewed literature, the study found that various oral cavity diseases and disorders have been associated with marijuana use, including abnormal oral dryness, caries, severe inflammation of the gums and dental framework, leading to loosening of the teeth and mucosal abnormalities. Since 1990, 3 reviews have summarized pulmonary changes found in individuals who smoke marijuana. These changes include lung injury, alveolar macrophage dysfunction, and an increased risk for pulmonary infections and respiratory cancer. The reviews also report that short-term use of marijuana is associated with modest bronchodilation, chronic cough, and increased sputum production, while chronic exposure to the THC is associated with decreased inflammatory reactions that could lead to increased pulmonary infections. This is especially important to consider with patients that we would be using medical marijuana with who are already in increased risk for lung infections. While the debate continues over the ethicality of medical or recreational marijuana, the number of patients who use marijuana has increased and will likely continue to increase. Therefore, it is essential for healthcare providers to know the healthcare effects of marijuana before it is implemented into the healthcare environment. Certainly, more research regarding the direct physical consequences of medical marijuana is required, although it must be first approved by the FDA.
appropriate to use. Some research has shown just the opposite, however, and there are 3 categories in which medical marijuana may be safer than other pharmaceuticals currently used. Those categories are overdose potential, toxicity, and tolerance. Medical marijuana can improve the symptoms of spasticity in multiple sclerosis sufferers, as Liz mentioned earlier, specifically for the treatment of spasticity, pain, and incontinence. Often the improvements were gained over and above the anti-spasticity medication being taken by the subjects during the study. In those patients, the positive effects often persisted in longer-term extension trials without tolerance. This was an unprecedented finding. Often anti-spasticity medication doses must be increased as time goes on, as the patient's body develops a tolerance to the medication. This is dangerous because the higher the dose of a drug, the higher the risk for adverse effects. In 2005, the Federal Drug Administration Adverse Events released a report on the number of deaths attributed to the use of 17 FDA-approved pharmaceuticals and the number of deaths attributed to medical marijuana. These 17 pharmaceuticals were drugs whose benefits could potentially be achieved by using marijuana instead, but marijuana is routinely not prescribed due to the illegality of its nature. The FDA-approved drugs included medications such as antiemetics, antispasmodics, and pain medication. The results were astonishing. 10,008 deaths were reported by healthcare professionals to have occurred primarily as a result of the medications administered. There were 0 cases in which marijuana had been the primary suspect of death. This evidence provides one of the strongest cases that although medical marijuana may have some documented side effects, other FDA-approved drugs that are being used for the same purposes as marijuana to be prescribed, the same purposes as marijuana is often used for having higher incidences of death. By not allowing marijuana to be prescribed when it may be a safer option than another drug is a violation of 2 ethical principles, beneficence and non-maleficence. Prohibiting the prescription of a drug with known benefits that has a lower chance of serious adverse events prevents good to be done to patients and in fact causes them harm. Ethically, as healthcare providers, we cannot allow this to continue. The toxic symptoms of marijuana have been cited by the FDA as sleepiness and reddened eyes. While these indeed may be unwanted by some patients, the current pharmaceuticals used to treat pain, emesis, and muscle spasms have toxic symptoms such as leukopenia, pain, constipation, hepatotoxicity, overdose, and death. We're not arguing that marijuana should be a first-line drug. There are many concerns still about regulating the dosage and the form in which it is ingested. But for some people in our population, especially those suffering from cancer or on palliative care, who could benefit from the positive benefits of marijuana, marijuana has been denied. Marijuana has been shown to increase appetite, decrease nausea and vomiting, decrease muscle spasticity, lower intraocular pressure, and relieve pain of a neurogenic nature. These benefits cannot be ignored. The Clinical Journal of Oncology Nursing published a case study in 2012 on the use of marijuana for palliative care in oncology patients. The article stated that rescheduling marijuana to a Schedule II drug would reflect the known medicinal value of marijuana while acknowledging the importance of proper medical supervision and accepting that more research is necessary into the side effects and dangers of medical marijuana use. While federal law counts marijuana possession as a criminal offense, the American Medical Association supports marijuana rescheduling to facilitate research and standardization. In the U.S., 18 states and the District of Columbia have legalized marijuana as of 2013. However, because of a lack of research, there is little known evidence-based practice on how to regulate marijuana's quality or potency, or how to obtain the drug. Is it ethical to keep marijuana as a Schedule I drug? It is not, as it violates the ethical principles of beneficence and non-maleficence. Rescheduling the drug to a Schedule II drug would open the door for medical professionals and medical researchers to better care for many types of patients.